Good evening and welcome to St. Vincent College and to the second lecture in the Physical Culture Education Series sponsored by the SBC Health and Fitness Club. My name is Nicholas Rapulia and I'm an assistant professor of finance here at St. Vincent and a starting strength coach. Before we begin, I'd like to offer a few words of thanks. First of all, to the St. Vincent Health and Fitness Club, led by Mara Fitzpatrick. You've done a great job at organizing this series. Please visit us at www.sbcfit.com. I would also like to thank SBC strength coach John Bell for his constant and unwavering support of us. And finally, I would like to thank the members of the Starting Strength Forum at startingstrength.com, many of whom drove considerable distances to be here. I am grateful both to Dr. Sullivan and fellow Starting Strength coach Chris Carisco for joining us tonight. Over the next several years, the Physical Culture Education Series will present talks about various aspects of health, fitness, nutrition, and training. We will take a reason-based approach and will challenge much of the conventional wisdom that surrounds these aspects of physical culture. Before we begin, some housekeeping. At the end of the formal presentation, Dr. Sullivan will take questions from the audience. Also, on your chair, you'll notice a note card. Please take a moment to fill out your name, email address, address, whatever you want to tell us if you'd like to get on our mailing list. And if there's any topics you'd like to see us address, please jot them down there. Leave them at the end of the lecture and our students will pick them up. Also, please enjoy a complimentary copy of Barbell Training is Big Medicine by Dr. Sullivan, which is one of the most compelling articles written about the benefits of resistance training. With our house in order, I now turn it over to junior finance major Andrew Hill. Thank you.
Hello, thank you for coming tonight. My name is Andrew Hilton. I'm the speaker coordinator for the St. Vincent Health and Fitness Club. Our speaker tonight, Dr. Jonathon Sullivan, is a former United States Marine. He earned his MD from the University of Arizona College of Medicine and completed his PhD in physiology at Wayne State University. Currently, he is the attending emergency physician at Detroit Receiving Hospital and associate professor at Wayne State University. As the owner of Graceville Strength and Conditioning and a starting strength coach, Dr. Sullivan is committed to helping people barbell training. He is the chair of the Starting Strength Association Science Committee, in which he helps further the research of strength training. His yearly review of this research of science and health strength training helps us to decipher the quality of research from the useless garbage that clogs the internet. As an emergency physician, he sees firsthand the effects of physical weakness and the complications that it can cause. Dr. Sullivan is a firm believer that barbell training is a fountain of youth that can help slow down the aging process. Dr. Sullivan is committed to helping people build a stronger and healthier lifestyle so they never have to meet him in the emergency room. Please give me a hand in welcoming Dr. Jonathon Sullivan.
Thank you very much. Is the sound okay? Can everybody hear me? Good. Thank you for the introduction. I'd like to thank Nicholas Rapulia and the St. Vincent's Health and Fitness Club for making me feel so welcome here on the beautiful campus tonight and for honoring me with the invitation to come and speak. I would also like to thank Andrew for making some of the arrangements for my stay. I want to thank my friend and department chair, Dr. Brian O'Neill, a physician's physician, who took my shift on Wednesday so that I could put some of the finishing touches on this presentation. I want to thank my beautiful wife, Marilyn, my lifting partner and life partner and my love, for indulging me in this extracurricular career, along with many other indulgences. And I want to thank my dear friend and benefactor and teacher, Mark Rigoto, the author of Starting Strength, without whose influence and guidance and kindness, I would not have embarked on the path that led me here to speak to you tonight. And finally, I want to thank my friend, the very strong Jordan Feigenbaum, who set off this lecture series earlier this year with an extraordinary presentation, an act I cannot hope to follow, and who chose to do so while wearing a suit and tie, thereby compelling all future speakers to be saying, "Thanks a lot, Jordan." Tonight, I would like you to join me in the exploration of a concept that has been gnawing at me for some time. The concept of the modern aging phenotypes, and in particular, the sick aging phenotype, which I conceive of as a syndrome of interrelated processes and abilities, particularly sarcopenia, frailty, the metabolic syndrome, and polypharmacy, terms which I will explain as we proceed. We will then examine the power of exercise medicine to combat this sick form of aging, and in particular the power of resistance training for strength. I'll put forward what I believe to be an excellent exercise prescription for those of us in our 5th decade and beyond. And in the process, we'll have an opportunity to touch briefly on what I consider to be an important and transformative picture of the aging adult. This is a full agenda, and our time is limited, so I hope you will indulge me. And I will be pleased to answer your questions at the conclusion of the presentation. So, let's begin. Now, humans are what we call polymorphs, like most animals. Our general human attributes take many forms. While we all share common hereditary and species-specific characteristics that mark us as members of a particular strain of hominid, we nevertheless display a vast range of physical, metabolic, and behavioral variations. That is, phenotypes. Phenotype is a strange but useful word, a construction from the Greek words phrenon and typos. It is literally the show type of an organism. Its observable, measurable characteristics, the culmination of influences from genetics, its development, its environment, its society, and its behavior. The phenotype is to be distinguished from the genotype. The genotype is the molecular blueprint of the organism. The phenotype is the actual construction that we end up with. And like any building, it will have additions and omissions and imperfections and marks of use and weathering and wear and tear, which are included in no book. Two organisms may have very similar or even identical genotypes and very different phenotypes. Now let me give you an example. Consider a pair of twins that I met in my emergency department some years ago, and encounters which affected me deeply. One of these sisters was my patient, the other her caregiver. My patient was morbidly obese, diabetic, hypertensive, and suffering from end-stage congestive heart failure. Her sister, her identical twin sister, was anything but identical. She suffered from mild hypertension, as many African Americans do, but her condition was well controlled. And she was lean, active, athletic, and in her late 50s, a very gorgeous example of healthy aging. She looked 20 years younger than her sister. Two ladies, same genotype, but very different phenotypes. What happened here? These ladies had the same molecular blueprint. They grew up in the same house. They watched the same TV shows, the same cereal commercials. They went to the same school. They had the same parents. They ate the same birthday cake on the same birthday. They were as alike as two human beings can be. And yet, their aging phenotypes, and ultimately their death phenotypes, would become very different in adulthood. We are left with little to explain their phenotypic differences without invoking, at least in part, their respective behaviors. My patient freely admitted that, unlike her sister, she had never taken care of herself. That she was sedentary and a smoker, had never been particularly compliant with her antihypertensive medication, and that even now, she rarely kept her doctor's appointments, and having no exercise tolerance, rarely left the chair, which had become her living space and her bed. The contracted horizon of a lonely and miserable existence. It was ultimately the behaviors, the ways of life, that brought these two ladies with identical genotypes to tragically different phenotypes. And so, while it is certainly possible for a sick aging phenotype to be the result of bad luck, bad genetics, bad environment, unexpected illness or injury, which cannot be controlled, there are modifiable behavioral factors that do contribute to the development of what I call a sick aging phenotype. Some of which behaviors are indicated here. And I maintain that this sick aging phenotype is a modern aging phenotype. The modern aging phenotypes comprise a spectrum. At one end, we have a healthy aging phenotype, exemplified by my patient's sister. Never before in history has this phenotype of aging been available, at least not to so many. It is made possible by advances in nutrition, medicine, preventative medicine, and particularly health care, by personal and social hygiene, and by the extraordinary prosperity, stability, and social justice of modern Western and industrialized societies. On the average, we actually don't achieve lifespans that are that much longer than our ancestors did in, say, medieval Britain, medieval Europe. Especially if we make it past the vulnerability of infancy and the exuberant, dangerous stupidity of adolescence. But unlike our ancestors, we have more opportunity than ever to achieve old age with more vigor, more health, more material prosperity, greater physical well-being, broader horizons, and more teeth. Unfortunately, the sick aging phenotype is, at least in my experience, rather more common than the healthy aging phenotype, certainly more common than it should be, and consuming a disproportionate share of healthcare and social resources. Like the healthy aging phenotype, the sick aging phenotype is a modern aging phenotype, made possible by abundance, modern medicine, particularly sick care, and by all the other advances of Western civilization that make it possible for us to live into our 50s or 60s or 70s without having to worry about smallpox, or plague, or dysentery, or famine, or the general war that we have somehow failed to ignite for the last 3/4 of the century, although you can't make some people for trying. Never before has it been possible for so many to reach middle age with so few infectious diseases, so many comforts, so many protections against ancient horrors, both man-made and natural, and with so many donors and so many hammers except for cost. So the healthy aging phenotype and the sick aging phenotype are modern aging phenotypes at the ends of a spectrum that encompasses many avatars of aging, and which in industrialized countries is skewing more and more toward the sick and the healthy. It's important that I disclose to you that this concept of a sick aging phenotype, this model, is a product of my own fevered imagination. It is rather new, and it will doubtless be subjected to criticism, constructive and otherwise. And even if it does prove to be useful and can be sustained, it will have to undergo refinement and revision over time as we learn more, and as I learn more. But as it stands, my model of the sick aging phenotype is a constellation of features that I encounter daily in my practice as an emergency physician. The sick aging phenotype is characterized by sarcopenia, that is, the loss of muscle mass, with attendant declines in bone density and bone mass, in physical capacity, and frailty, plus the metabolic syndrome, which is not one of my concepts, but rather a very well-recognized constellation of clinical features driven by insulin resistance. And the sick aging phenotype also includes polypharmacy and medical dependence. Now, there's a lot going on here. Even though this model of the sick aging phenotype is of necessity a distillation, a simplification, a model. Just as an example, frailty is a term that is much used in the geriatric literature, but here I'm using it in a rather more expansive and idiosyncratic way. In my formulation of the sick aging phenotype, frailty is a term that covers a multitude of sins. It refers not only in its usual sense of physical susceptibility to illness and injury, but also to a general failure of function, independence, and human dignity. It's not just the inability to fight off the complications of influenza or a broken hip. It's the inability to fight off the complications of life itself. It's the loss of ability to engage in the activities of daily living, to engage in the pursuits that bring us joy and self-actualization. It's loss of autonomy, of sexual function, of cognitive function, of self-respect, and even hope. Frailty, as I use the term in my formulation of the sick aging phenotype, encompasses horrors and miseries too depressing and manifold to enumerate here. It's like Dante's use of the word inferno, one word to indicate a descent into entire realms of suffering. Bearing all this in mind, that this is a model that we're talking about, let's take a closer look at the development of this sick aging phenotype. How does it come about? There are many places we can begin, but I wish to focus for the moment on the metabolic syndrome. Notwithstanding factors beyond our immediate control, genetic and environmental factors, it seems clear that lifestyle variables are sufficient to drive the development of the metabolic syndrome. Excessive positive energy balance, too many Big Macs, not enough exercise, leads to deconditioning, the loss of muscle tissue, and the accumulation of fat, particularly visceral fat, that is, fat around the internal organs. The loss of muscle and the accumulation of visceral fat are profoundly dangerous to our health. Muscle, we have learned recently, is actually an endocrine organ. That is, it's a kind of gland. And its disuse and atrophy lead to an abnormal profile of myoclines, which are hormones of muscle tissue origin. Fat also turns out to be a kind of a gland. And its accumulation on the trunk and around the internal organs in the setting of decreased physical activity results in an abnormal and unhealthy adipokine profile, adipokines being hormones of fat origin. Eventually, visceral obesity, excessive caloric intake, and decreased physical activity produce a state of insulin insensitivity, or insulin resistance. In this state, insulin is still produced, but the responsiveness of tissues to insulin is limited. This has profound, widespread effects. Obviously, the control of serum glucose, or blood sugar, will be affected. Blood sugar will be high, But the transport of sugar into cells is inhibited, and a state of insulin resistance resembles, in some respects, a fasting state, a starvation state. Insulin resistance has been linked to the suppressed release of nitric oxide, an important signaling molecule for the regulation of blood vessel tone, which will ultimately promote the development of hypertension, high blood pressure. Insulin, beyond being a glucose-regulating hormone, is also a growth hormone. And the loss of insulin signaling is also a loss of growth factor signaling, with very unfortunate effects for aging tissues throughout the body. And finally, the accumulation of visceral fat and the loss of insulin sensitivity results in a pro-inflammatory state, with increased release of C-reactive protein, inflammatory cytokines, necrosis factor, and other inflammatory molecules that cause degeneration and damage, with attendant pain and loss of function. This insulin resistance is modeled here for you in a couple of cartoons that really oversimplify the issue, but will give you some ideas. In the normal state, feeding and increased blood glucose result in the release of insulin, which acts at a cellular receptor, these Y-shaped guys over here, to promote the translocation of glucose transporters to the cell membrane. It's these glucose transporters that are the gateways for glucose to enter the cell. But in a state of insulin resistance, insulin receptors are, as they say, down-regulated, in precise term that will do for our purposes. The receptors are fewer in number, or less responsive, or both. So although the blood is full of glucose and insulin, there isn't a robust response by insulin signaling systems. And glucose transporters are not moved to the cell membrane in sufficient numbers to deal with the elevated blood glucose. And the decreased number and responsiveness of insulin transporters has other widespread effects as well on growth, repair, cellular survival, and gene expression. As the syndrome matures, we see the onset of hypertension, or high blood pressure, the silent killer, which contributes to arteriosclerosis, heart disease, and stroke, among other miseries. The systemic inflammation I spoke of earlier wreaks havoc on many tissues, including muscles, joints, blood vessels, and even neurological tissue. And the blood lipid profile becomes deranged, with increases in bad cholesterol and serum triglycerides, which are thought to contribute to the development of vascular disease and heart disease. That's an overview of the metabolic syndrome. And it's bad enough, but it's not the whole story of the phenotype. This graphic representation will help us flesh out the picture. The initial state is here, with modifiable factors shown in blue. Now, in truth, all of these factors have some impact on each other. I've just indicated here, for example, the interplay between culture and environment and our diet. Too many Big Macs, not exercise, and increased positive energy flux leads to the accumulation of fat, and particularly visceral fat. And decreased physical activity, along with aging itself, leads to muscle atrophy, the loss of muscle tissue, which also leads to decreased physical activity. You see a loop, a positive feedback here. When you encounter a loop like that in a pathophysiological process, you have trouble. The process becomes self-reinforcing and harder to arrest. Obesity, visceral fat, muscle atrophy, all conspire to create this state of insulin resistance, which worsens muscle atrophy and the accumulation of visceral fat, more loops. The syndrome is getting stronger. Insulin resistance, as we've seen, leads to high blood sugar, hyperglycemia, high blood pressure, systemic inflammation, and dyslipidemia. These factors in gray are the components of the metabolic syndrome. And sarcopenia, And so what we have here is the first tier, if you will, of the sick aging phenotype. Sarcopenia increases insulin resistance. Insulin resistance increases sarcopenia. The syndrome progresses over time to the second tier, more of an end stage sick aging phenotype characterized by diabetes, heart disease, stroke, frailty, pain and degeneration, and arteriosclerosis. We talked about loops, pathophysiological processes, positive feedbacks. Here, it's getting positively graded, where these processes continually feed into each other and reinforce each other, making the syndrome more and more refractory. And pretty soon, you're in a hole that is very, very difficult to dig out. This is the sick aging phenotype. We haven't even talked about polypharmacy and medical dependence here. As the syndrome progresses, the patient becomes increasingly dependent on medical intervention for physiological stability and symptom relief, if not health. And this promotes the development of polypharmacy, which is simply a fancy word that means many drugs. And it's epidemic in older populations. It's not uncommon for a patient to come into the emergency department literally with a shopping bag full of prescription pills. And in a context which makes it absolutely clear that she has no idea what she's doing. One pill bottle was filled a week ago. It's almost empty. One was filled 6 months ago. It's almost full. Multiple doctors on these prescriptions. And so we have a patient who's on 2 or 3 antihypertensives to lower her blood pressure, a diuretic for the fluid retention, aspirin, clopidogrel to stomp her platelets into submission so she bleeds easily and bruises easily, sleep aids, antidepressants, narcotic pain medications, and of course prednisone, chronic inflammation. The patient will present saying that she's dizzy and tired. Well, of course she's dizzy and tired. We doctors have been poisoning her for years. And she needs these poisons just to live from one day to the next. Her medicines cause side effects, and we prescribe more medicines for the side effects. It's a bitter, dire trap, almost inescapable. The sick aging phenotype will ultimately progress to one of a number of sick death phenotypes. Now, of course, death comes for us all, as even for kings he comes, as a man for all seasons, Thomas More would tell us. But death tends to come in more unpleasant guises and to stay longer and to take more time with his work for those who suffer from the sick aging phenotype. Indeed, one of the main benefits of the healthy aging phenotype is not a longer natural lifespan, which is beyond the power of any medicine that I know, but a contraction of morbidity, a shorter death span, a shrinking of the dying part of our lives into a thinner and thinner slice of time. If we're lucky, of course, any misfortune may befall anybody, and a strong, healthy person who is taking care of him or herself may be struck down by illness or injury, just as a wise, rich investor can be ruined by a market crash. But in general, compression of morbidity is a benefit that cannot be expected by those with a sick aging phenotype. The end of that type of aging is, in general, more miserable, more horrific, and more drawn out. For my money, the most obscene and terrifying prospect is that of the nursing home principal. Demented, diapered, immobile, living in a purgatory of indescribable suffering. Contracted limbs, bed sores, feeding tubes, chronic dehydration, intractable pain, often without even the ability to cry out for relief. Recurrent bouts of pneumonia and sepsis until finally there's nothing left. The last ICU stay. The last festival of needles and catheters and ventilators and hospital beds. The sick aging phenotype does not always end so horrifically, but the sick aging phenotype is, by any estimation, a catastrophe, a train wreck. I love these old pictures of train wrecks for some reason. But, of course, we're talking about a modern phenotype, so perhaps this image is more appropriate. I'm pretty sure all these fellows have read are mountains, looking on with a sort of helplessness, and I can relate. In my professional life, I am confronted daily by a sense of powerlessness before this sick aging phenotype, this sick aging train. I have no drugs, no injections, no surgical procedures that can treat it at the root causes. Only pills and potions to normalize this or that laboratory value, or to ease the discomfort, or to put off the race of death a little longer. Now, of course, there is a medicine that gets to the root of the sick aging phenotype. And that is, for want of a better word, and I do want a better word, lifestyle medicine. It's only in the modern era that we've really forgotten that the way we live is a sort of medicine. Good medicine or black medicine, depending on the way we live. On what we eat, on how we work, on how we play, on which intoxicants we use, and how often, and how we treat our fellows, and how we live in society. Obviously, today's lecture focuses on one particular facet of lifestyle medicine, exercise medicine. When integrated into a healthy life, this is the most powerful medicine in the world for the sick aging phenotype and its components. Exercise has powerful effects against sarcopenia, frailty, and the metabolic syndrome. And so, exercise gets to the root of the sick aging phenotype. Exercise, any form of vigorous exercise, depending on its formulation, intensity, and regularity, is likely to have manifold beneficial effects on musculoskeletal, restoring muscle mass, restoring bone density, restoring tendon and ligament stiffness, the promotion of favorable myokine and adipokine profiles, on cardiovascular health. It's essential to cardiac function. We see improved cardiac function, retarding the development of vascular disease, fighting hypertension. On metabolic health, exercise increases insulin sensitivity and decreases visceral fat. It gets to the root of the metabolic syndrome. On cellular health, increasing the resistance of cells to reactive oxygen stress, free radicals, promoting the development of more mitochondria, the powerhouses of the cell, and decreasing cell suicide, which we call autophagy and apoptosis. And even on neurological health, on maintaining brain plasticity and decreasing the loss of brain tissue and aging. And so, I think exercise is, in a limited sense, a fountain of youth, or at least a fountain of health. But just so we're all keeping our feet firmly on the ground, let's be clear that there are limits to what even the most powerful medicine in the world can do. Aging and disease bring about structural, cellular, and molecular changes that are either extremely difficult or thermodynamically impossible to reverse. So exercise won't really make us younger, of course. It won't cure diabetes or cancer. It won't shrink your prostate or your balls spot. And it won't make you happy. I'm convinced that one can only be happy, not be made to be happy. Be all that as it may, exercise can make us better and stronger and healthier. And yes, even more beautiful, if not by the standards of Hollywood. It's not magic, but it is powerful. Truly the most powerful medicine in our armamentarium. Which raises a critical question. What is the correct exercise prescription for the aging adult? We think of exercise as a medicine, then a rational exercise prescription will have the same requirements as any other prescription. It's not hard to come up with a list of such requirements. Our exercise medicine must be safe. I trust I'll get no argument there. The exercise prescription must allow for a broad range of dosing. We must be able to start at a low dose, and as we get healthier, increase the dose, the exact opposite of all other types of medicine. The exercise prescription must be comprehensive. It must address a broad range of general performance attributes, body composition, and energy systems. The exercise prescription must specifically and substantively address the sick aging phenotype. And finally, the exercise prescription must be as simple as possible, but no simpler. It is my position that the foregoing considerations will lead us to this. The general exercise prescription for the aging adult will take the form of a training program for the master's athlete. Now, there are two big ideas at work. The first idea is that if exercise is a medicine, the most powerful medicine, then it should be as explicitly and specifically prescribed as any other medicine. No physician would tell his patient, just get some medicine. Or write a prescription that said antibiotics. But some of these same physicians are perfectly comfortable telling their patients, just get some exercise. Go to the gym. Go for a walk. That will not do. A proper exercise prescription must specify the formulation, the dose, the schedule, and the route of administration. And in the case of exercise medicine, that means it must specify the type of exercise, and it must rationally manipulate training variables, volume, intensity, set design, duration, rest intervals, recovery duration, and so on. This very special form of exercise, rationally and specifically prescribed to drive targeted improvements in physical attributes over time, is what we call training. And individuals who engage in training to optimize their physical performance and body composition are what we call athletes. Athletes do not exercise. They train. They engage in carefully crafted, long-term programs of general physical development. And this most emphatically includes athletes of aging, what we call the masters athlete. The second big idea is closely related, but more fundamental, more powerful, and more transformative. It is simply that the aging adult must cease to think of him or herself as an old man, or as an old woman, or as sick, or frail, or weak, as a victim, or even as a patient, an identity that some people positively cling to. Instead, she must think of herself as an athlete of aging, as a master's athlete, engaged in the most brutal sport of all, getting older. She may, in fact, be sick and frail and fat and weak, but armed with the mentality of the athlete, she thinks of these not so much as debilities, which they are, but more as opponents who challenge her against the clock in the arena of life and time. As long as she prepares to grapple with these foes by training for that arena, she is an athlete. Now, this might seem like semantics, just words, but our world, and especially our inner world, is dominated by words, by signs and symbols and ideas. And I have found that this change in headspace, this change in self-identification, is liberating, empowering, and transformative. So, strongest and most effective exercise prescription for the aging adult is a training program for the master's athlete. And that program will be focused on strength training with barbells. Now, this position flows from the criteria I laid out in the previous slide for the formulation of an exercise prescription. I do not count the time this evening to substantively lay out this argument for barbells, although the argument is there. Others have made it, and I will present it in other venues and other media. But if I can impose upon you to reserve judgment on that point for the moment, I will use the remainder of my time to focus on the effect of resistance training of any type, barbell or no barbell, on the sick aging phenotype, and in particular, on the metabolic syndrome. So let's take a look. You will recall that the metabolic syndrome is composed of these components: truncal obesity, visceral fat, insulin resistance, hypertension, dyslipidemia, and systemic inflammation. Let's start with truncal obesity and visceral fat, and we'll go through these things quickly. Consider first the paper by Campbell in the American Journal of Clinical Nutrition, 1994. Small study of older adults who gained fat-free mass and lost fat on a resistance training program for strength. Or the study by Ibanez et al. In Diabetes Care, 2005. A small, uncontrolled study, an observational study, 16 weeks of resistance training reduced visceral and abdominal fat and increased insulin sensitivity. A limited study, but a positive result. And I'm not going to gloss over the limitations in some of these studies. I'm going to show you this literature, warts and all. Arturos et al., the Journal of Clinical Endocrinology and Metabolism, 2005, a one-year study, an unusually long study of resistance training, a randomized control trial, where men were randomized either to high-intensity resistance training or low-intensity resistance training. Both programs decreased leptin, a bad at the time, and only high-intensity resistance training increased adiponectin, a good at the time. High-intensity resistance training is most effective at reducing fat and improving the adiponectin profile. Strasser et al., a literature review, Obesity, 2011. Resistance training is at least as effective as aerobic endurance training in reducing some major cardiovascular disease complications. Resistance training preferentially mobilizes visceral and subcutaneous adipose tissue in the abdominal regions. For now, you all know what the importance of that is. Tracieres et al., a literature review. Resistance training improves body composition with increases in fat-free mass and decreases in abdominal and visceral mass. And so, there are contrary studies, in particular the 2012 meta-analysis by Ishmael et al., which I have some methodological issues. But on the whole, the evidence strongly indicates, but does not prove, that resistance training decreases abdominal and visceral fat and produces favorable adiponectin profiles. And these effects appear to be accentuated by the combination of resistance training with a conditioning program. Let's turn more briefly to insulin resistance, which, as you'll recall, is the core of the metabolic syndrome. Here, there's no shortage of literature, and most of it is good news. This study by Pacheco on clinical interventions in aging, 2013, a randomized control trial of 20 postmenopausal women assigned to either a control group or progressive strength training group with 10 exercises, 3 sets of 8 reps each, a very silly machine-based program with no structural exercises. The resistance training group showed decreases in a metabolic syndrome Z-score, composite score for the risk of developing metabolic syndrome, and improvements in strength and body composition and glycemic control. The title wildly overstates the conclusions. They actually did not look in a longitudinal fashion at the rate of progression of these individuals to the full-blown metabolic syndrome. Their findings on the Z-score and glycemic control were quite enough. Why they had to overstate their conclusions, I don't know. Welcome to the literature. Castaneda et al. diabetes care, we've already seen this. These people showed an increased muscle glycogen, a sign of insulin signaling, a trend towards decreased plasma fasting glucose, and a decrease in the requirement for their anti-diabetic medications, and a decrease in their HbA1c, their glycosylated hemoglobin, a measure of long-term glycemic control, long-term control of blood sugar. And more, Grunfeld et al. This is what we think is going on here. In the untrained individual with poor insulin sensitivity, when the blood glucose goes up, the insulin goes up, but the insulin signaling is decreased. There's decreased glucose transporters to the membrane. We've already seen this. But it turns out that during exercise, glucose flux is insulin independent. Exercise alone is enough to stimulate the movement of glucose transporters to the membrane so that the muscle can take up glucose. And this persists for some time after exercise. But after the exercise stop, the muscle says, we're going to need more glucose transporters if he does that again tomorrow. And so the muscle actually increases the pool of available glucose transporters. And so in the trained individual, we see an increase in insulin sensitivity and an expanded glucose transport pool. Improved glucose sensitivity, and improved insulin sensitivity, and improved glycemic control. That's a simplification of what seems to be going on with exercise. There are, again, contrary studies. For example, the study by Gersdorf, a fairly well-done study of elderly Icelanders that found no difference, although the Icelanders got stronger. I don't know how you feel about stronger Icelanders, but there it is. On the whole, however, the available evidence strongly indicates that resistance training increases insulin sensitivity and improves glycemic control, promotes both insulin-dependent and insulin-independent muscle glucose disposal, reduces the level of hemoglobin A1c, and may prevent the progression of metabolic syndrome to full-blown type 2 diabetes. Hypertension. Again, no shortage of data. I'll make this short for you. The preponderance of the evidence suggests that resistance training, contrary to what your grandma might have told you, does not make you have high blood pressure. In fact, the data suggests that resistance training is good for high blood pressure and helps prevent the progression of early-stage hypertension to full-blown hypertension, and may even, in some cases, increase the need for medication. The data on resistance training for hypertension is limited, both in quality and in quantity. But again, on the whole, the available evidence indicates that resistance training decreases both systolic and diastolic blood pressure and may reduce, but not eliminate, the need for antihypertensive therapy in some subjects. When we look at dyslipidemia, the derangement of serum lipids, the data is rather more mixed. For every study showing an improvement in serum lipids with resistance training, there's another that shows no difference. When you look at this literature, studies that report positive changes appear to use higher intensity protocols, in other words, more high-dose resistance training, suggesting a dose responsive. And combining resistance training with conditioning improves serum lipid responses. And finally, if we look at systemic inflammation, we find some positive data in the literature. For example, this study by Phillips et al., a non-randomized controlled trial of 23 women, average age 65, undergoing 12 weeks in a short duration study of resistance training. The authors reported improvements in strength and in response to endotoxin. They actually put endotoxin in these ladies, a bacterial toxin, and decreased C-reactive protein, leptin, and tumor necrosis factor serum. So, I think you see where I've been going with this. Resistance training has positive effects on multiple components of the metabolic syndrome, fighting the accumulation of visceral fat, increasing insulin sensitivity and improving glycemic control, decreasing hypertension and systemic inflammation, with its effects on dyslipidemia being rather more murky for the moment. Strength training fights the metabolic syndrome. And it does this in spite of the almost universal use of low-dose resistance training in this literature, the lack of structural exercises like squats and deadlifts, and standing presses, and pathetically short study durations that systematically and disproportionately shortchange strength training. Unlike endurance training, which is dependent primarily on enzymatic adaptations and the fine-tuning of energy systems, which the body can accomplish quite quickly, strength training requires not only changes in energy utilization, but also the construction of new tissue, muscle, bone, tendon, which takes a long time, especially in older adults, and which benefit cannot be fully realized in the 8 or 12-week interventions used in most studies. But even in the face of these handicaps, resistance training shows itself to be a powerful medicine. Strength training fights the metabolic syndrome. Well, what if it didn't? I maintain that even if we were to adopt an unreasonably skeptical view of the accumulating data on strength training and the metabolic syndrome, strength would still demand a central role in the exercise prescription for the Master's Act. You will recall, after all, that the sick aging phenotype is more than just the metabolic syndrome. It is also muscle atrophy, sarcopenia, the associated loss of bone mass, and an expansive concept of frailty with all the misery that entails. The sarcopenia, the loss of muscle tissue, is endemic in many populations, affecting a quarter to over half of such people, and that, under a most conservative definition of sarcopenia, that may not be appropriate. Modern ideas about what constitutes healthy muscle mass in older adults may well be open for revision. It's as if we were saying that a healthy 401k for a 60-year-old should have at least $100,000. This loss of muscle in aging appears to be due in part to a disproportionate loss of type 2 fibers. As some of you may be aware, muscle fibers, which are muscle cells, come in three flavors. The slow twitch fibers, the aerobic fibers, which have very high endurance, low fatigue ability, but which are weak and small. And then there are two types of fast twitch fibers, two types of type 2 fibers, which for our purposes are more like enzyme different, and which are larger, more easily fatigued, less capable of doing aerobic metabolism, and much more strong and powerful. When we look at the literature, there are strong indications that the loss of muscle tissue in aging is dominated by the loss of these high-powered type 2 fibers. Consider, for example, the study by Milwick, a very important paper. Milwick and his co-authors took 25 girls and 26 geezers and had them undergo DEXA scans and CT scans and muscle biopsies pre and post 6 months, a long period of resistance training. Perhaps I should say that geezers is a term of endearment, self-applied. And in fact, in our community, we have an entire taxonomy of geezers. Older lifters may be geeslings, geezoids, geezettes, geezers, geezosaurs, or geezoliths. Perhaps we should turn to the matter at hand. Milwick found, when he did this study, that the muscle cross-sectional area was lower in geezers, no surprise there. The type 1 fiber size was smaller in geezers, but the type 1 fiber number was largely unchanged. Training increased type 1 fiber size, but not number. The differences in muscle size between the geezers and the bros, and between pre and post training, was almost entirely due to a 2 fiber size difference. They concluded that the loss of muscle tissue, the loss of muscle size, cross-sectional area, and aging is primarily due to the atrophy, but not the loss of type 2 muscle fibers. In other words, what they found was that sarcopenia in aging is dominated by the loss of the strongest, most powerful, largest fibers. But they're just sort of ghosts, and they can be brought back to life by training. And the increase in muscle size with fibers is dominated by the return and the increase in size of these high-powered type 2 muscle fibers. That's huge. That is simply huge. But even if we set that aside, it is incontrovertible that resistance training for strength can increase muscle mass, bone density, power, and function in older adults, even the very aged. This requires a specific reformulation of programming and diet to overcome age-related anabolic resistance, to avoid overtraining, and to maintain progress. In particular, older adults seem to be what Andy Baker and I, colleague of mine, who recently coined this term, volume-sensitive, intensity-dependent. Too much volume will crush them. But if you back off too much on the intensity, they'll lose their gains. So we need to tend to keep the weight rather high in older lifters, but we tend to decrease their volume to improve their recovery. Modifications like this can help us get people stronger for a long time, even very old. And so, like Jonathon Sullivan in this paper published in the journal Preventive Medicine in 2000, I have been led to conclude that resistance training is an effective tool against the metabolic and frailty syndromes. And by now, I hope that you have a better idea of just how incredibly important is such a claim. My prescription for the aging athletes is a training program for the masters, a long-term regimen for the optimization of health, function, and body composition. And it uses barbells. Again, I do not have the time tonight to lay out the argument for why barbells are the resistance training modality par excellence. That is another topic for another time. But for now, I assert that they are safe with a minimum of unexpected impulsive forces and joint works. They are exquisitely dosable. I can add as little as a half a pound on a client's barbell, and I can start her out on a broomstick if need be. A year later, I can have her deadlifting 100 pounds, 150, 200 pounds. Barbell training is comprehensive, maximizing the recruitment of muscle mass, loading the spine and hips, tapping into all three energy systems, and training full mobility and balance. As we have just seen at length, a resistance training program for strength addresses the sick aging phenotype. And this is most emphatically true of barbell training as well, because barbell training is the most powerful form of resistance training, permitting the most weight to be lifted through the largest range of motion. And finally, barbell training is efficient. 4 exercises programmed over 2 or 3 days a week is all it takes to get stronger. And when we add a conditioning component, we're cooking with gas. We intensify all these benefits, but that doesn't have to mean long, slow distance training like jogging or running. It can mean intervals, sprints, kettlebells, you name it. In the starting strength community, we like the Prowler type of sled for its intensity, its simplicity, its versatility, and its time efficiency. It has no eccentric component, so it allows us to condition without soreness and without major impediments to recovery. Here is Gus at the Wichita Falls Athletic Club, Mark Ripper's gym, pushing the prowler at the age of 91. I had the honor of meeting this lady earlier this month. Not long ago, before she started her strength and conditioning program, she told me she was as weak as a kitten, unable to get around her own home without assistance or walk. This is her walk. So, there we have it. Our exercise prescription for the aging adult, our training program for the Master's Athlete. It's what me and Jordan and others have come to call barbell medicine, a special kind of exercise medicine that puts strength first, because it is strength, or lack of it, that dominates our physical aging feedback. The pattern of a healthy life is not dominated by the need to go out and run 10 miles. It's rather more about pushing a wheelbarrow, or heaving a suitcase overhead onto a shelf, lifting a heavy bag of groceries up off the floor, rising from an orange chair to greet a friend, or power hitting a granddaughter on our shoulders. With barbell medicine, we can make all of these movement patterns, which are the patterns of our lives, the patterns of our physical lives, we can make them stronger and more powerful, and optimize our potential to realize a healthy aging feedback. This little gift is a sort of tribute to all of my clients, not all of whom are pictured here. None of these people are under 50. And most of them are well into their late 60s. They incarnate what I've been talking about here, the mentality and the practice of the Master's Athlete. This lecture is dedicated to them. They are my inspiration, they are my pride and joy, and they honor me and humble me by allowing me to train them. I leave you with them, and I thank you for your kind attention. Any questions? Sure.
Your aspect of bottom medicine, but the corresponding component of dietary and nutritional corresponding to promoting changes. I guess it's my understanding that as aging increases, that it is more difficult to add muscle mass, and it is more imperative that a proper dietary regimen be followed. What would your recommendation be with what diet should be, but also is there a role of supplementation in this, and how does it play, I guess, along with disease and medication, the medicine is treating short? How does that reflect?
It's an excellent question. I don't know if everybody heard it. We're being asked about the dietary intervention, especially in the context of strength training and the addition of muscle mass. The problem with the addition of muscle mass as we get older is that there are multiple factors that create a sort of anabolic resistance. This has recently been dealt with definitively by Dickinson in an excellent review. And anabolic resistance is multifactorial. But the end of the lesson here is that we can overcome it, even in older adults, by engaging in resistance training with significant intensity, and by eating more protein, and in particular, taking branched-chain amino acids. And so, under Michigan law, as a trainer, I'm not allowed to give nutrition advice. As a physician, I'm perfectly fine with nutrition advice, even though, as a physician, most of us don't know what we're talking about when it comes to nutrition advice. But in my gym, I'm not allowed to give nutrition advice. So I always tell people, hypothetically, if I were to tell somebody, I would simply observe that older adults require more, not less protein, and more, not less branched-chain amino acids to turn on an insulin-dependent signaling system called the AKT-mTOR system that upregulates protein synthesis in multiple settings, including the setting of resistance training. The more protein and more amino acids you take, the more you're able to overcome the anabolic resistance to protein and amino acids that occurs as we get older. So that protein generally and that amino acid should be taken right soon after a bout of resistance training, when the muscle is most primed to receive that anabolic signal. So I do is I eat almost as soon as I put the bar on the rack. Put the bar on the rack. During my last workout, I'm drinking branched-chain amino acids. I put the bar on the rack and I go eat steak, or I go eat some chicken, or I go eat some fish. And that's all I eat, actually. I don't usually take a mixed meal because there's some data, not particularly good data, to suggest that a mixed meal immediately after training may actually make it harder for the cell to respond to that anabolic signal. Long story short, you have to train hard and you have to eat your meat. How can you get any muscle if you don't eat your meat? Next question. Yes, ma'am. You'll have to speak loudly on just a bit hard to hear you.
I actually have two questions. The first one is the structural exercise you're talking about. Is that like what we're seeing in the video, the deadlift, the squat, things like that? Okay.
Right.
And then secondly, what do you say to people when they talk about arthritis and injuries? Older people a lot are concerned about worsening their arthritis or creating an injury. So what do you
Two
say?
very excellent questions. The young lady asked first about structural exercises, which I sort of glossed over. What is a structural exercise? Well, a structural exercise is an exercise that you don't get on a machine. A structural exercise is an exercise that loads the axial skeleton, the spine, the pelvis, the hips. It's an exercise. It's a kind of loading that you can't get sitting down in the press machine, or sitting down in the curl ball, or in the leg press. It's an exercise that structurally loads the axial skeleton, the spine, the pelvis, and the hips. It's squats, deadlifts, standing overhead presses, and any pull from the floor, snatches, cleans, and related exercises. That's what a structural exercise is. The second question was about arthritis. And there is some data on that. And properly performed and programmed, no, resistance training will not keep your arthritis worse. In fact, it will increase your mobility. It will improve the angle of attack of muscle fibers around joints, increasing the strength of those joints, adding stability to the joints, increase the stiffness of ligaments and tendons around joints. And there's some tantalizing data, not clinical data, but very tantalizing data, that the load that is transferred to cartilage by structural exercises, the loading of joint tissues by resistance training, actually increases the flow of synovial fluid through that cartilage to help oxygenate it and deliver nutrients to a tissue that is notoriously avascular and notoriously atrophic. So, at both the basic science level and the clinical level, there is no proof that properly performed resistance training will make arthritis worse, and every indication that resistance training will improve function in chronic arthritis. Good question. Thank you. Sir?
I know, especially for older adults and older adults that haven't been exposed to for older adults that haven't been exposed to resistance training before, that might have trouble with the full range of motion or not be strong enough to move a barbell yet, how do you approach getting them stronger up until they can do a proper squat, deadlift, or press?
Anybody hear that? Not hear that question? How do we deal with very older, frail, or relatively immobile older adults who want to train? who have trouble performing a squat, like say standing up out of a chair, right? Or have trouble bending over and picking something up off the floor. How do we approach it? Very carefully. In my gym, the first thing I do is I perform a movement assessment. Rick will love that. Movement assessment. Not a functional movement screen, but a movement assessment. What I always tell people is, if you can stand up out of a chair, pick a kitten up off the floor, raise your arms up over your head, and push something away from you, you can get stronger. You can do a program of barbell training. But some people can't do that. And there are modifications of these exercises, ancillary exercises, auxiliary exercises that we can use to help some people. And quite frankly, some of these people simply have to undergo some sort of specialized rehabilitation to regain their range of motion and their conditioning before they can safely strength train. Sir?
Could you comment on free weights versus the barbell training, and also the quantity or amount of weight that you should be striving to whatever?
The argument for barbells is a long and involved one, but it simply boils down to this. With barbells, as opposed to machines, I can lift the most weight over the largest range of motion, right, in a way that involves you standing, not sitting, so you have to control where the barbell is in space. You have to control the center of gravity, the center of mass of the barbell lifter system. So it doesn't just train strength, but it trains mobility, and it trains balance. So that's part of the argument for why barbells, why free weights instead of machines. And barbells can be loaded more exclusively. As I said before, I can put a 10-pound aluminum barbell on the back of a fairly big trainee, and I can add a half a pound of food. And before she knows it, she done went without smoke. Sir?
Yeah, let me ask you a question about some of the metaphors that you just used. Now, I recognize that sarcopenia doesn't have an accepted precise definition. But in one sense, it's not a disease. It is a description of the fact of the human body that as we get older, we lose muscle. And use of the term athlete comes from the Greek word alcohol, which derives from con. Again, I would say we're not in a contest with death. We are not to defeat death. We are mortal to the beings and we will die. So, again, the notion of athlete is a little problematic here in terms of that's a contest in what is the contest. Again, we've got morbidity versus mortality. And yes, we don't want to be diseased, but yet we will die. And so I understand that what's important for us to maintain a level of strength and endurance that will allow us to maintain our life activities in as high and a fulfilling fashion as we can. But to suggest that it's a contest against death, you did not say that some of the metaphors.
I'll say it. It's a contest. And it's a contest that
we cannot win that contest. We will all not.
Does a contest always imply that there can be no preordained winner or loser? There can be no. The word athlete, that it comes from the presence, which means something like contestants, also something like combatants. The ancient Olympic Greek Games were the full slice of life, and they were brutal. They evoked not so much the niceties of the modern playing field as the ancient battlefield. The javelin throw, wrestling, boxing, and the poplitodromos, the race in full battle. They were bound up with a lot of cultural and political significance, and the stakes were high. An athlete who won might be housed and fed and clothed for his entire life, and his feats chronicle for the ages. And an athlete might be maimed or killed. It was what we think of today as athletics. So there is a lot in the word athlete. But I'm using the word to indicate not just that kind of thing, but also the mentality of somebody who is engaged in training. Athletes train. They don't exercise. They train. They engage in systematic, long-term programs for the optimization of general physical attributes and body composition. That's what athletes do. So if you reject a more expansive idea of what an athlete is, I think you have to at least accept that. As for regarding death as a combatant, as a contestant against death, well, I have to say that's a philosophical issue, and you've heard my philosophy. It's a value-based philosophy, and like Wittgenstein, I don't think there's any fact of the matter that can decide between our positions. It's simply my values versus your values. My values are that I will not go quiet. I will not dwindle. I will not, if I can, show up at another ER doctor's emergency room as a wheezing, weak puddle of atrophic fat. That, the sick aging phenotype, is not for me. I will fall, and I will lose, but I will fight. But that's me.
You presented a false dichotomy between the warrior who triumphs over death versus the fool of fact. And there's something in
There are many things in between, as I have indicated. There are many other phenotypes. I have given you my version.
And I just suggest that it strikes me that it might be a bit extreme, and that it might be, again, it's an alternative vision of the world.
I would invite you, sir, to walk a mile in my shoes, to see what I see every day. What I see every day calls for powerful ones, strong ones. Sir.
Well, I think first of all, I so very much appreciate your time and thought this evening. I don't ask for a question, but a couple of observations based upon my own experience. I've been working with Nicholas for several months now on the Starting Strength program. And two things. One, it was interesting to learn the science behind why I feel good. And in so many different aspects. The second one is that structural training, the input of an instructor, somebody who really knows what they're doing, can, even when you don't understand the science and all those other things, make really sense on the right path. The third thing is, and it really gets to how this is hard work. I was developing the program for a number of months, and then I had a real nasty bout of bronchitis in my respiratory system, and I had to lay off for a while. I just couldn't keep up August as fast. When I came back, I said, geez, this is hard. This is hard work. And I forgot about it because it was a gradual pace. But when I had to lay off, when I came back, you're actually right. You are training, and it's tough work.
It's a struggle. Yeah. And it takes a certain amount of grit and courage to get on the platform to begin with, or after a layoff, or even in the course of regular training. It is hard work. It's a medicine that you have to deliver to yourself. This medicine is on you.